Today I will talk about approach to a case of pulmonary thromboembolism in emergency. First is the disclaimer. Acute pulmonary embolism is a life-threatening condition which occurs when blood clot that has arisen from different areas obstructs the pulmonary arteries. Most commonly, the pulmonary embolism originates from a deep vein thrombosis in the lower extremity. Together, pulmonary embolism and DVT comprise venous thromboembolism. It is a significant cause of morbidity and mortality worldwide. So, prompt recognition and management of pulmonary embolism are critical as delayed intervention can lead to severe complication including hemodynamic instability, right ventricular failure and sudden death. The origin of thrombus is usually from the deep vein thrombosis in the lower extremity, valvular sinuses, mainly the calf vein, pelvic veins like iliac and femoral vein, and other sites are, though less common, renal vein, upper limb vein, right side of the heart, in situ thrombus in the pulmonary circulation. Coming to the pathophysiology, pulmonary embolism occurs when the blood clot blocks the pulmonary arteries, most commonly in the lower lobes and often affecting both lungs. The large emboli can obstruct the main pulmonary artery, leading to significant cardiovascular compromise, while smaller emboli may cause pulmonary infarction. The obstruction disrupts the gas exchange by creating a ventilation-perfusion mismatch, which increases the dead space ventilation and leads to hypoxemia. Chemical mediators like serotonin further exacerbates the vasoconstriction, reducing the pulmonary blood flow and triggering respiratory alkalosis. The mechanism or the mechanical blockage and the hypoxic vasoconstriction increases the pulmonary vascular resistance, raising the pulmonary artery pressure when it becomes more than 30 to 50% of the vascular bed is affected. This overloads the right ventricle, causing dilation, septal bowing, and reduced left ventricular filling, which leads to decreased cardiac output, systemic hypotension, and potential shock. Acute right heart failure is the primary cause of death in severe pulmonary embolism. The risk factors are usually contributed by venous stasis, hypercoagulability, endothelial injury, and this triad of venous stasis, hypercoagulability, endothelial injury is called virtuous triad, and it is responsible for the risk factors for pulmonary embolism. Risk factors can be classified as genetic or acquired ones. Genetic risk factors includes thrombophilia, for example, factor 5 Leiden mutation, prothrombin gene mutation, protein C deficiency, protein S deficiency, hyperhomocystinemia. Acquired risk factors include immobilization for prolonged period, for example, patients who are bedridden for more than 3 days, or any type of air, train, or bus travel of more than 4 hours, recent orthopedic surgery, malignancy, indwelling venous catheter, obesity, cigarette smoking, pregnancy, and oral contraceptive pill use. These are the acquired risk factors. Stasis is contributed by surgery, trauma, immobility, paralysis, increased age, pregnancy and postpartum, heart or respiratory failure, obesity. The vessel injury is due to previous DVT, smoking, varicose vein, central venous catheterization, and hypercoagulability is attributed to increasing age, malignancy, cancer therapy, estrogen therapy, acute medical illnesses, inflammatory bowel disease, nephrotic syndrome, myeloproliferative disorder, paroxysmal nocturnal hemoglobinuria, inherited or acquired thrombophilia. We can classify the pulmonary embolism as acute, subacute, chronic depending upon the onset. Patients with acute pulmonary embolism, they typically develop the symptoms and sign immediately after the obstruction of the pulmonary vessels, and those with subacute presentation, they may have symptoms delayed for days or weeks following the initial event, and patients of chronic pulmonary embolism develop symptoms over months or years. Similarly, we can categorize pulmonary embolism as massive pulmonary embolism, submassive, and low risk pulmonary embolism. Massive pulmonary embolism accounts for 5 to 10% of the cases. It affects almost half of the pulmonary vasculature. Patient presents with dyspnea, syncope, hypotension, and cyanosis. Patient can have cardiogenic shock, and this may lead to death of the patient. Submassive pulmonary embolism accounts for 20 to 25% of the cases. RV dysfunction is also there despite normal systemic arterial pressure. Low risk pulmonary embolism is seen in 65 to 75% of the cases, and it carries excellent prognosis. Patient can be categorized based on the presence or absence of hemodynamic stability, and this is very crucial in the management of the patients with pulmonary embolism. Hemodynamically unstable pulmonary embolism, which is also previously called as massive or high risk pulmonary embolism, it results when patient has hypotension, which is defined as systolic blood pressure less than 90 mm of mercury, or when there is drop in systolic blood pressure of more than equal to 40 mm of mercury from the baseline, or any degree of hypotension that requires vasopressors or inotrophs, and such patients are categorized as hemodynamically unstable pulmonary embolism, and these patients are more likely to die from obstructive shock because of severe right ventricular failure. Then we have hemodynamically stable pulmonary embolism. It is a spectrum which ranges from small, mildly symptomatic or asymptomatic pulmonary embolism that causes mild hypotension that stabilizes in response to fluid therapy, or those that presents with right ventricular dysfunction, that is some massive or intermediate risk pulmonary embolism, and but they are hemodynamically stable. So hemodynamic classification of pulmonary embolism is massive pulmonary embolism when it is associated with shock or hypotension. Such patients needs thrombolysis. Some massive pulmonary embolism when there is uh, RV dysfunction on echocardiography, or patient has elevated troponins and BNP. These patients may need thrombolysis or catheter-based intervention. And low risk pulmonary embolism when the patient is hemodynamically stable, patient has no RV strain on the echocardiography, and these patients are treated with anticoagulants only. Patients of pulmonary embolism present with signs and symptoms with acute onset. So the timely diagnosis of pulmonary embolism is critical because it carries a very high mortality. If left untreated, 30% of the patients die as compared to the 8% if they receive the early treatment. Symptoms are dyspnea at rest or with exertion. It is seen in 73% of the cases. Pleuritic chest pain seen in 66% cases due to pulmonary infarction. Patient may have platypnea, cough or thigh pain or swelling due to DVT. Patient may have hemoptysis, dry cough. Signs are tachycardia or dyspnea, which are of new onset, especially in the hospitalized patient. Patient may has raised JVP, loud P2, deep vein thrombosis in the lower limb. The specific features of massive embolism are hemodynamic collapse, that is asystolic blood pressure less than 90 mm of mercury, elevated JVP, crushing chest pain, severe dyspnea, severe hypoxia. So just remember that a patient with sudden dyspnea and tachycardia but with normal lungs on auscultation, we should always suspect pulmonary embolism. These are the signs and symptoms with their frequency. I have taken this slide from up to date. So,
Whenever the patient
whenever the patient comes to us with sudden onset of dyspnea or tachycardia, we should think of pulmonary embolism, and we do a pre-test probability, that is risk stratification, and we use this Wells criteria or modified Wells criteria uh, to assess the case for pulmonary embolism. If patient has clinical symptoms of DVT, that is leg swelling, pain with palpation, then we give 3 points. If patient has pulmonary embolism and we are highly suspicious of pulmonary embolism as compared to other diagnoses, then again we give 3 points. If the heart rate is more than 100, we give 1.5 points. If patient has history of immobilization for more than or equal to 3 days or surgery in the previous 4 weeks, we give 1.5 marks or points. Previous DVT or pulmonary embolism, we give 1.5 points. If the patient comes with hemoptysis, we give 1 point. If the patient has history of malignancy, we give 1 point. And we calculate the score. If the score is more than 6, then we categorize it as high risk pulmonary embolism. Uh, Probability of high risk pulmonary embolism. If the score is between 2 to 6, we categorize that moderate, and if the score is less than 2, then we categorize it as probability of low risk pulmonary embolism. Similarly, the modified Wells criteria is used nowadays. If the score is more than 4, we say the pulmonary embolism is likely, and if it is less than equal to 4, we say that it is pulmonary embolism is unlikely. So whenever we get the score of more than 4, then there is high probability of pulmonary embolism. We should as well always go for imaging, that is CT pulmonary angiography as CT pulmonary angiography. If the score is 4 or less than 4, we should do first the D dimer test, and if it comes positive, then we should proceed with CT pulmonary angiography. Even if the score is less than 4 and the patient has a high risk, then we should always do CTPA. We can remember this Wells criteria by using this mnemonic: don't die, tell the team to calculate criteria. D in don't is DVT, D in die is diagnosis of pulmonary embolism is most likely, T is tachycardia, T is 3 days of immobilization or surgery in past 4 weeks, T is the thromboembolism, T is tumor, C is coughing up of the blood, that is hemoptysis, and C is the criteria, that is clinical suspicion of pulmonary embolism. So if the score is more than 4, then PE is likely. If the score is 4 or less than 4, we say it as it is P is unlikely. So once we have done the risk stratification by using Wells criteria, we then do diagnostic approach. We initial tests which are done are ECG, chest X-ray, ABG, D-dimer, CTPA. If CTPA is contraindicated, for example, in patients with renal failure, we should do BQ scan. So, uh, for diagnostic evaluation of acute pulmonary embolism, once we have done with the Wells criteria, then we will do the arterial blood gas analysis. The arterial blood gas analysis, uh, the findings will be widened alveolar arterial oxygen gradient, respiratory alkalosis, and low CO2. In severe cases or massive pulmonary embolism, patient may show acidosis due to shock. So the patient will have low PCO2, low PO2, normal or low PCO2 and will have type 1 respiratory failure in ABG. The chest X-ray is usually normal if pulmonary embolism is not massive, but it may show non-specific signs like atelectasis, effusion, or may have wedge-shaped segmental opacities. For example, in pulmonary infarction, Hampton's hump, Westermarck sign. This helps us to rule out the other causes of breathlessness. In ECG, the patient ECG may be normal if the pulmonary embolism is not massive or submassive. The commonest finding is the sinus tachycardia, but the patient may have right axis deviation, a right ventricular hypertrophy, right bundle branch block. S1Q3T3 pattern is specific pattern, but it is a rare finding. It is seen in less than 6% of the cases. Patient may have atrial fibrillation and this predisposes to pulmonary embolism. Next test is a D dimer. Elevated D dimer suggests a blood clot but very sensitive and non-specific. Negative D dimer rules out the pulmonary embolism. The D dimer can be positive in sepsis, myocarditis, recent surgery, pregnancy. Age adjusted cutoff for D dimer is age in years into 10 nanogram per ml for the patients who are more than 50 years of the age. So it means normal value for D dimer is we usually consider more than 500. If the patient's age is 60 years, then for him the normal value will be 60 into 10, that is 600 nanogram per ml. Then we do troponin elevated in 30 to 50% of the moderate to large pulmonary embolism, indicating a right heart strain. It is used for risk assessment but not for the diagnosis. We can use BNP. Elevated BNP suggests a right heart strain, but it is not diagnostic for pulmonary embolism. Higher levels may indicate severe right ventricular dysfunctions. The ECG in pulmonary embolism, though this S1Q3T3 pattern is uh, specific, but it is a rare finding. It is only seen in less than 6% of the cases. Routine biochemistry, we can do CBC, ESR, LDH, LFT, RFT, EGFR. Then we can do echocardiography. In echocardiography, we will get RV dysfunction or hypokinesia, a right wall motion abnormality, sparing the RV index. It is called McCollin signs, high PA pressures, visualized clot, right ventricular hypertrophy, right atrial enlargement or tricuspid regurgitation, loss of inspiratory collapse in inferior vena cava. Always remember that a normal echo rules out a significant pulmonary embolism. We can do computerized tomographic pulmonary angiography. It is a gold standard for diagnosing pulmonary embolism. It defines the arteries involved, shows the abrupt cutoff at the site of embolism. It is 100% sensitive, 91% specific. If CT pulmonary angiography is contraindicated, then we can do VQ scan. For example, in patients with renal failure, pregnancy, it also helps in assessing the right heart strain. Right ventricle left ventricle ratio, if more than 0.9, it predicts a severe outcome. So we should avoid CT pulmonary angiography in patients with allergy or renal failure is if in renal failure patients with EGFR less than 30. If CTPA is contraindicated, for example, in patient with pregnancy, contrast allergy, we do ventilation-perfusion scan. Normal scan excludes the pulmonary embolism. High probability scan suggests pulmonary embol. Pulmonary angiography, though it was initially done, but nowadays it is rarely used. Invasive procedure, it was performed when CTP and VQ are inconclusive. It can be combined with catheter-based treatment. Then magnetic resonance angiography, not routinely recommended due to its low sensitivity and usually the results are inconclusive. Advantage is that there is no radiation exposure. It is useful when CTPA or VQ scan cannot be done. Venous Doppler can be done to look for deep vein thrombosis, but we know that several small emboli from the pelvic veins or other veins can come which cannot be detected by the venous Doppler. Laboratory tests they are not diagnostic, but they alter the clinical suspicion for pulmonary embolism and confirm the presence of alternative diagnosis. They provide the prognostic information in the event that pulmonary embolism is diagnosed. The CBC serum chemistries may show leukocytosis, increased ESR, elevated serum lactate level, elevated serum lactate dehydrogenase level, EST level, serum creatinine, and estimated glomerular filtration rate helps in determining the severity of administering the contrast for angiography. Then we do hypercoagulability workup for proven cases of pulmonary embolism where we suspect genetic cause. For example, in patients with factor 5 Leiden deficiency, prothrombin gene mutation, protein C and S deficiency, antithrombin 3 deficiency, antiphospholipid antibody, serum homocysteine, neoplasm, and connective tissue disorder. So, just to summarize the diagnostic approach, we have to do first risk stratification with well score. Then we do initial type tests like ECG, chest X-ray, ABG. If patient has very high probability in Wells criteria, then we can do CTPA directly. It is a gold standard method. If there is low probability, we do D-dimer test. If D-dimer test is negative, then pulmonary embolism is ruled out. If D-dimer is positive, then we do CTPA. That is CT pulmonary angiography. If CTPA is contraindicated, then we do renal, for example, in patients with renal failure, then we do VQ scan. Then there is another pulmonary embolism exclusion criteria. It was developed for emergency department patients to select the patients with low likelihood of having pulmonary embolism. That diagnostic workup should not be initiated. If these criteria are met, then we don't go for the uh, diagnostic workup for pulmonary embolism, and they constitute variables significantly associated with the absence of pulmonary embolism. The pulmonary embolism exclusion criteria has 8 variables, like if the age is less than 50 years, heart rate less than 100 beats per minute, oxygen hemoglobin saturation more than 95%, no hemoptysis, no estrogen use, no prior DVT or PE, no unilateral leg swelling, no surgery or trauma requiring hospitalization within the preceding 4 weeks. For patients who fulfill all these 8 criteria, they have very low probability of pulmonary embolism, and the likelihood of pulmonary embolism is sufficiently low that further testing is not indicated. But this pulmonary embolism exclusion criteria is only valid in clinical settings where there is low prevalence of pulmonary embolism, that is less than 15%. Pulmonary embolism exclusion criteria should not be used in patients with intermediate or high suspicion of pulmonary embolism or in patient suspected of having pulmonary embolism. So whenever we evaluate a case of pulmonary embolism, we do evaluation based on his low probability, intermediate probability, and high probability. Coming to the evaluation of the adult with low probability of pulmonary embolism, we when we do when we suspect pulmonary embolism, we do well scoring. If it is less than 2, then it is a low probability, then there is low probability of pulmonary embolism. Then we see, can pulmonary embolism rule out criteria be applied? We apply the PERC formula if it is well score is less than 2, that is age less than 50 year, heart rate more less than 100, oxygen hemoglobin saturation more than 95%, no hemoptysis, no estrogen use, no diabetes or pulmonary embolism, no unilateral leg swelling, no surgery, trauma requiring hospitalization within the prior 4 weeks. If this formula can be applied, मतलब, and answer to all these questions is yes, then pulmonary embolism is excluded. No further testing is needed. If answer to above test is to all these questions is no, then we measure the D dimer. Okay, if the D dimer is less than 500 nanogram per ml, then it means pulmonary embolism is excluded. We will not do any other further testing. If D dimer is more than 500 nanogram per ml, then we do CT pulmonary angiography. If the CT pulmonary angiography is feasible, yes, then we do CT pulmonary angiography. If it is positive, then it is pulmonary embolism is diagnosed. If CT pulmonary angiography is negative, then pulmonary embolism is excluded. If it is inconclusive or cannot be done, then the ventilation perfusion scanning is planned. If it is feasible and it is done, and if it is normal or low probability result, then pulmonary embolism is excluded. If it is not normal or not feasible, then further testing is warranted. This was the algorithm for patients, adults with low probability of pulmonary embolism on Wells score. Then patients with intermediate probability of pulmonary embolism. Here the score will be, well score will be between 2 to 6. We have to measure the D dimer level. If the D dimer level is less than 500, then pulmonary embolism is likely excluded. No further testing is required. If D dimer is more than 500, then we again follow the same process as we followed in the low probability score. If this CT pulmonary angiography is possible or feasible, we do CT pulmonary angiography. If it is positive, pulmonary embolism is diagnosed. If it is negative, pulmonary embolism is excluded. If CT pulmonary angiography is inconclusive or if it is not feasible, then we do ventilation perfusion scanning. If this is uh, possible and we do ventilation perfusion scanning, and then if it is normal, then pulmonary embolism is excluded. If it is not normal, then further testing is required. Similarly, uh, we do this evaluation. This is the algorithm for high probability of pulmonary embolism. If there is high probability of pulmonary embolism, that is well score is more than 6, then the CT pulmonary angiography, we have to see if the CT pulmonary angiography is feasible or not. If yes, then we do CT pulmonary angiography. It is positive, then pulmonary embolism is diagnosed. If it is negative, then pulmonary embolism is excluded. If CT pulmonary angiography is inconclusive or not feasible, then we do ventilation perfusion scanning. If this ventilation perfusion scanning is feasible and normal, then pulmonary embolism is excluded. If it is low or intermediate probability, then further testing is warranted. And if ventilation perfusion scanning shows high probability, then pulmonary embolism is diagnosed. If ventilation perfusion scanning is not feasible, then further testing is warranted. Coming to the complications of pulmonary embolism, patient with pulmonary embolism can have sudden death, obstructive shock, pulseless electrical activity, atrial or ventricular arrhythmia, carpulmonary lung infarction leading to ARDS, pulmonary hypertension. If we see that um, this in pulmonary embolism, the clot obstructs the pulmonary artery or the arteriolar flow. If the clot prevents the blood flow to the lungs, it leads to ischemia, lung infarction, inflammation, and which further leads to acute respiratory distress. And if because of clot there may be failure to oxygenate, failure to ventilate, patient will have respiratory failure. If there is increased pulmonary this clot will cause increased pulmonary artery pressure, which will lead to congestive heart failure, that is right sided heart failure. Patient will end up with cardiogenic shock and pulseless electrical activity. If this process remains chronic, then patient will develop pulmonary hypertension. The differential diagnosis of pulmonary embolism or MI. Here, the patient of MI will have retrosternal pressure radiating to jaw, arm, or neck. Risk factors include long-standing hypertension, diabetes, hypercholesterolemia. Patient with pneumonia can present with cough, purulent sputum, fever. Pneumothorax patient will have history of recent trauma to the chest, decreased breath sounds unilaterally, hyperresonance or percussion of affected side, deviation of the trachea away from the affected lung. Patients of congestive heart failure will have acute exacerbation, will have history of orthopnea, paroxysmal nocturnal dyspnea, increased bilateral lower extremity swelling, diffuse crackles on pulmonary auscultation, elevated jugular venous pressure. Patients of pericarditis will have chest pain that improves when sitting up and worsens when supine. Patients of cardiac tamponade will have back strides of hypertension, muffled heart sound, elevated jugular venous pressure. Patients of panic disorder will have sudden onset anxiety, feeling fainting, and palpitation. These episodes will be recurrent and will have discrete period of intense fear or discomfort. Coming to the initial approach and resuscitation in pulmonary embolism, whenever the patient of pulmonary embolism comes to us and we are suspecting it as a pulmonary embolism, then we should always stabilize the patient, and priority should be stabilizing the patient while conducting the clinical evaluation diagnostic test. If the risk of pulmonary embolism is high and bleeding risk is low, we should always anticoagulate such patient even before confirming the diagnosis. Once confirmed, the risk stratification is crucial to determine further management and whether the patient needs transfer to higher facility or not. Then we do hemodynamic stability assessment. The management of suspected PE depends whether patient is hemodynamically stable or unstable. Hemodynamically unstable patients are high risk or massive pulmonary embolism cases are the patients who develop hypotension, that is systolic blood pressure less than 90 mm of mercury for more than 15 minutes, or drop of more than equal to 40 mm of blood pressure, or patients who needs vasopressor, and these patients are at high risk of shock or cardiac arrest and they require immediate resuscitation. Hemodynamically stable patients are the patients who do not meet the above criteria for instability. They range from low risk to intermediate risk, and these patients may deteriorate over time, requiring the close monitoring and possible therapy adjustment. The initial management will be for stable patients, supportive care with IV access, oxygen, fluids, empirical anticoagulation if pulmonary embolism is uh, if pulmonary embolism suspicion is high and bleeding risk is low. The diagnostic test is we usually do CT pulmonary angiography. The suspicion is very high. For unstable patients, we have to focus on restoring the blood pressure, oxygenation with fluid, vasopressor, mechanical ventilation may be required if needed. Immediate anticoagulation with unfractionated heparin is done. If patient is too unstable for CT pulmonary angiography, we use bedside echocardiography to detect the right heart strain or clot. If echocardiography, if echocardiography is unavailable, then we do systemic thrombolysis as it is a life-saving measure. Patients who deteriorate despite anticoagulation, they may need urgent thrombolysis or embolectomy. Role of DVT is linked to poor PE outcome and can help guide risk assessment even though it is not the part of current treatment or evaluation. How do we assess the hemodynamic stability? Just we see whether patient is hemodynamically stable or not. If patient is hemodynamically stable, we we have to think that patient we have to anticoagulate such patients. If the anticoagulation is contraindicated, then we use the diagnostic evaluation, and we have to exclude the PE. And if patients who are hemodynamically stable, we have to see whether patient is hemodynamically stable or not. If patient is hemodynamically stable, then we have to see whether anticoagulation can be given to him or not. If anticoagulation is contraindicated in such patient, then we will do diagnostic evaluation and we have to exclude the pulmonary embolism. If pulmonary embolism is excluded, no further evaluation is needed. If pulmonary embolism is confirmed, then as anticoagulation cannot be done, then we will use or we will give inferior vena cava filters. If the patient is hemodynamically stable, anticoagulation is not contraindicated, and we see that patient has a clinical suspicion of acute pulmonary embolism is low, then with diagnostic evaluation, it we this diagnostic evaluation may take longer than 24 hours, then we can anticoagulate such patients. If the diagnostic evaluation will not take less than 24 hours, then no anticoagulation is needed. Okay, if the patient with moderate suspicion for acute pulmonary embolism and we are doing diagnostic evaluation, if we think that the diagnostic evaluation will take more than 4 hours, then we will anticoagulate such patient. If diagnostic evaluation will not take more than 4 hours, then we will not anticoagulate such patient. If the suspicion of pulmonary embolism is very high, then we will anticoagulate such patients. And with the same anticoagulation, we will be doing diagnostic evaluation. If the pulmonary embolism is excluded, then we will discontinue the anticoagulant and seek alternative cause for the symptoms. If in diagnostic evaluation the PE is confirmed, then we will see whether the clinical severity needs for these patients further need thrombolysis or not. If yes, then we will thrombolize the patient. We will try to thrombolize the patient and we will see whether there is any contraindication to that or not. If there is contraindication to thrombolysis, then we will do surgical or catheter embolectomy, and if there is no contraindication, then we will hold on anticoagulation, administer the thrombolytic agent, then resume the coagulation. If there is clinical improvement, then we will continue the anticoagulant. If there is no clinical improvement, then we will do surgical or catheter embolectomy. So if we patient's clinical condition does not warrant thrombolysis, then we will continue his anticoagulants. This was about the stable patients. If patient is not hemodynamically stable or patient is hemodynamically unstable, then we will follow this algorithm. If the patient is unstable, then we will do the resuscitation. Hemodynamically unstable, we will do the resuscitation. While doing resuscitation, we will reassess. If still he is hemodynamically unstable, then portable perfusion scanning or transthoracic echocardiography can be done. If transthoracic echocardiography shows evidence of RV overload, then we will try to use thrombolytic therapy. If thrombolytic therapy is contraindicated, then we will do surgical or catheter directed embolectomy. If thrombolytic therapy is not contraindicated, then we will hold on anticoagulation and administer him thrombolytic agent and then resume the anticoagulation. Then we will see his clinical improvement. If there is clinical improvement, we will continue the anticoagulation. If there is no clinical improvement, we will repeat systemic thrombolysis, catheter directed thrombolysis, surgical or catheter directed embolectomy. If there is no evidence of RV overload, then we will search for other causes of hemodynamic instability. If the patient is hemodynamically unstable, after resuscitation, if the patient is stable if he becomes hemodynamically stable, then we will follow the algorithm for the stable patients. This is the algorithm I think which we must uh, take out its print and paste it in our emergency ward. So initial therapies for pulmonary embolism are respiratory support, give supplementary oxygen to maintain oxygen saturation to more than 90%. In cases of severe hypoxemia, shock, respiratory failure, consider intubation and mechanical ventilation. Be cautious in patients with right heart failure as intubation can cause hypotension, and in such cases we should always consult a cardiovascular anesthesia expert and avoid high ventilatory pressures. ECMO, that is extracorporeal membrane oxygenation, may help in severe cases with refractory hypoxia or hypotension. For hemodynamic support, IV fluids like 250 to 500 ml of normal saline for hypotension can be given. However, in patients with right ventricular dysfunction, excessive fluid can worsen the right ventricular failure. So, use with caution, and if perfusion remains inadequate, we should start vasopressor. Norepinephrine is preferred. It is effective with less risk of tachycardia. Dobutamine increases the heart contraction but may cause low BP when it is. We should combine it with norepinephrine initially. Dopamine and epinephrine may be used but can cause excessive tachycardia. So empiric anticoagulation is we should start anticoagulation based on the bleeding risk and pulmonary embolism suspicion. Low risk bleeding, if there is low bleeding risk, we should start anticoagulation. If pulmonary embolism is highly suspected, that is well score is this I have already discussed in the algorithm. If well score is more than 6 or if testing will take long. If there is high bleeding risk, for example in patients with recent surgery or active bleeding, we should not anticoagulate. We should consider alternative like IVC filter or embolectomy. Patients with moderate bleeding risk, this differs case by case decision based on risk benefit. So the anticoagulant of choice is low molecular weight heparin. It is preferred in stable pulmonary embolism with normal kidney function. Unfractionated heparin, it is better in unstable pulmonary embolism due to possible thrombolysis and embolectomy. Direct oral anticoagulants, they are avoided in unstable patient, and hemoptysis due to pulmonary infarction is not a contraindication for use of oral anticoagulants. Definitive therapy for pulmonary embolism. If the pulmonary embolism is ruled out, we should stop the anticoagulation. If it was started empirically, we should look for other causes of patient symptom. If pulmonary embolism is confirmed and then if the patient is hemodynamically stable, patient with low or intermediate risk, we should give anticoagulation if the bleeding is low. If anticoagulation is contraindicated, we should place the IVC filter. We should avoid thrombolytic therapy unless deterioration occurs. For patients with intermediate or high risk, we should monitor closely for deterioration. We should consider thrombolysis or catheter-based therapies in selected cases. For hemodynamically unstable patients with shock or hypotension, such patients need immediate thrombolysis or catheter-directed therapy if contraindication exists. Anticoagulation therapy we should start immediately if the bleeding risk is low. Duration is minimum 3 months for all pulmonary embolism patients. Indefinite anticoagulation for high risk cases, unprovoked pulmonary embolism, persistent risk factor, estimated risk of bleeding and recurrences as well as patient preferences and values also decides the duration of anticoagulation therapy. Coming to the reperfusion therapy for pulmonary embolism, for reperfusion, we use thrombolytic therapy, that is clot dissolving drugs. They are used in hemodynamically unstable patients, patients with shock, severe hypotension, systemic thrombolysis. IV administration is preferred when there are no contraindications since it is faster than catheter-based approaches. Catheter-directed thrombolysis is an option for selected cases, for example, patients with high bleeding risk or systemic thrombolysis. If systemic thrombolysis fails, the options include repeated thrombolysis, catheter directed thrombolysis, catheter or surgical embolectomy. And embolectomy is indications are patients who cannot receive thrombolytic agents, for example, patients with recent surgery or active bleeding. Failure of thrombolysis in critically ill patients, types of embolectomy. Surgical embolectomy requiring cardiac surgery team, catheter-based embolectomy, it is preferred in if the expertise is available. Catheter-directed technologies are ultrasound-assisted thrombolysis, rheolytic embolectomy, rotational embolectomy, suction embolectomy, thrombus fragmentation. Surgical embolectomy is considered for patients in shock who cannot receive thrombolytics or have failed thrombolysis. They require a cardiac surgery team and cardiac pulmonary bypass. Mortality rate varies from 2 to 40%, 46%, but outcomes are better in stable patients. Extracorporeal membrane oxygenation, veno-arterial ECMO, can be used as a bridge therapy in massive pulmonary embolism cases where thrombolysis is contraindicated or as a support before surgery or catheter-based treatment. Medical management, which I have already discussed, the anticoagulation use are heparin therapy, unfractionated heparin. It can be used as a bolus or infusion. Enoxaparin given in a dose of 1 milligram per kg twice a day. Dalteparin given as 200 units once a day. Fondaparinux given as a 5 milligram, 10 milligram, 20 milligram per day. The oral anticoagulation therapy, warfarin usual starting dose is 5 milligram. For LMWH, UFH or fondaparinux are effective bridging agents for 5 days. INR target is 2 to 3. The side effects of the oral anticoagulants are hemorrhage. New non-warfarin anticoagulants are novel oral anticoagulants like apixaban, dabigatran, rivaroxaban. Apixaban is a dose is 10 milligram BD for 1 week followed by 5 milligram BD. Dabigatran 5 days for 5 days of UFH or LMWH followed by 150 milligram BD. Rivaroxaban is given as 15 milligram BD for 3 weeks followed by 20 milligram OD. Various thrombolytic agents which are used are urokinase, streptokinase, alteplase. So the if we see the anticoagulation with heparin, the risk factor for bleeding are age more than 65 years, previous history of bleeding, thrombocytopenia, antiplatelet therapy, alcohol abuse, or liver failure, recent surgery. The choice of anticoagulation is low molecular weight heparin. It is preferred over uh, ultrafiltered heparin. Low molecular weight heparin or enoxaparin, dalteparin, fondaparinux, unfractionated heparin is given as a bolus and continuous infusion to achieve APTT of 2 to 3 times the upper limit of normal. Initial dose of unfractionated heparin is 80 units per kg bolus, then 18 units per kg per hour or 500 units eighth early subcutaneously. The choice of anticoagulation. All patients with pulmonary embolism they will require anticoagulation for prevention of recurrence. They should be started after parenteral anticoagulation for first 5 to 10 days. Novel oral anticoagulants, these are preferred over warfarin. They have proven better efficacy, but they do not need PT monitoring. Direct thrombin inhibitor like dabigatran 150 mg twice daily can be given. Factor 10A inhibitors like apixaban, it is given as 10 mg BD for 7 days followed by 5 mg BD. Sorry, my slides are overlapping. Rivaroxaban, it is given in 15 milligram BD for first 3 weeks followed by 20 milligram OD for 6 months followed by 10 milligram OD later. Rivaroxaban and apixaban can be started without parenteral anticoagulation. Dabigatran needs to be given only after parenteral anticoagulation is done. Vitamin K antagonist, it is preferred over novel oral anticoagulants in the following conditions like pregnancy, renal failure, Epla syndrome. Warfarin is given as 5 to 10 milligram daily to attain a target PTINR of 2 to 2.5. In Epla, target PTINR is 2.5 to 3.5. Esenocomerol is 1 to 10 milligram adjusted to target PTINR. Definitive therapy is thrombolytic therapy. The indications are high risk with hemodynamic instability, severe RV dysfunction, severe hypoxia, high clot burden, intermediate risk with adverse clinical feature not responding to anticoagulation. The absolute contraindication for thrombolysis or fibrinolysis are prior intracranial hemorrhage, intracranial neoplasm, ischemic stroke within 3 months, active bleeding or bleeding diathesis, significant head and face trauma within 3 months. Relative contraindications are severe uncontrolled hypertension, pregnancy, active peptic ulcer, age more than 75, current use of anticoagulants, with INR 1.7, major surgery less than 3 weeks. The anticoagulants which are preferred in pregnancy are LMWH in 0 to 12 weeks. In 12 to 36 weeks, we give warfarin. After 30 weeks, 6 weeks, we give low molecular weight heparin, and during delivery, we can give unfractionated heparin. The dose adjustment in renal failure are for dabigatran. If the GFR is less than 50, we give 110 milligram BD. We should not use it if the eGFR is less than 30 ml. Rivaroxaban, it is given if the GFR is less than 50. The dose is 15 milligram or diapixaban. If age is more than 80, creatinine clearance is more than 15 milligram per deciliter, and weight is less than 60 kg, we give 2.5 milligram BD. For warfarin or acinocomerol, no dose adjustment is needed in renal failure. So thrombolytic regimes are streptokinase we give as 2 lakh 50,000 units over 30 to 60 minutes, followed by 1 lakh units per hour for 24 hours. It can cause anaphylaxis. Hence, steroids and chlorpheniramine can be given 30 minutes before the injection. Bleeding risk with streptokinase is very high. Tenecteplase single IV bolus can be given. If patient is 60 kg, we give 30 milligram. If 60 to 70 kg, we give 35 milligram. If 70 to 80 kg, we give 40 milligram. If 80 to 90, we give 45 milligram. If more than 90 kg, we give 50 milligram. If more than 75 years of age, we have to reduce the dose to half. Similarly, we can give retiplase. It is given as 10 unit IV bolus over 2 minutes. Then second dose is given as 30 minutes after the first, for total cumulative dose of 20 units in a dedicated line. TPA, that is alteplase, can be given as 100 milligram IV over 2 hours. In pulmonary embolism related arrest, 50 milligram IV bolus of TPA over 2 minutes. We have to repeat after 15 minutes in the absence of return of spontaneous circulation, and we can give TPA till 14 days after PE has occurred. Urokinase dose is 4,400 units per kg IV over 10 minutes, followed by 4,400 units per kg per hour for 12 hours. Successful thrombolysis lower the death rates and recurrent pulmonary embolism by dissolving the thrombus and prevents the release of serotonin and other factor causing PAH. Lysis of thrombus in deep leg veins and such, hence preventing the recurrence. The catheter-directed thrombolysis can be tried in a patient not responding to above measures. Embolectomy in patients who have contraindication for thrombolysis or do not respond to catheter-directed thrombolysis. For patients with submassive and mild pulmonary embolism, low molecular weight heparin followed by oral anticoagulants will suffice. So duration of therapies for patients with pulmonary embolism, minimum of 6 months full dose. We should de-escalate to lower doses after 6 months and given up to 12 months. For patients with procoagulant state and malignancy, lifelong treatment is required. Coming to IVC filter, patient with absolute contraindication to anticoagulation therapy, for example, hemorrhagic stroke, significant active bleeding, patient with massive pulmonary embolism who survived but in home recurrent embolism is possible and may be fatal, patient who developed recurrent venous thromboembolism in spite of adequate anticoagulant treatment, retrievable or permanent filter can be placed according to patient's clinical condition. Coming to outpatient versus inpatient treatment, outpatient treatment is safe in selected low risk patient. For example, patient with pulmonary embolism, severity index in home, this is low. Patient who do not require oxygen, no need to use narcotics, stable, their vitals are stable, they have good social support. Studies suggest that similar outcome between outpatient and inpatient anticoagulation in low risk patient. Subsegmental pulmonary embolism. Here, the incidental or isolated subsegmental pulmonary embolism, it has an uncertain significance. Here, if there is no risk of DVT or low risk of recurrence, we should monitor without anticoagulation. If multiple subsegmental pulmonary embolism or risk factors are there, then we can think of anticoagulation. Treatment of pulmonary embolism special population. The initial approach for pulmonary embolism generally same for all patients. However, in some special cases, the choice of anticoagulation may differ. Patient with cancer, here the preferred anticoagulants are low molecular weight heparin, edoxaban, apexaban, as they have been studied in cancer patients. For pregnant patients, low molecular weight heparin subcutaneous is the safest option for both mother and baby, used for both initial and long-term treatment. Patient with heparin-induced thrombocytopenia, all heparin including low molecular weight heparin, they are contraindicated. We should use a non-heparin anticoagulants like ergotraben ergotraben instead. Patient with inherited clotting disorders like thrombophilias, in most cases treatment is similar to general pulmonary embolism management. So special cases like antithrombin deficiency may require antithrombin administration. Patient with antiphospholipid syndrome, here the direct oral anticoagulants are generally avoided. Warfarin or heparin based therapy is preferred. Adjunct therapy for pulmonary embolism. In addition to anticoagulation, certain supportive and adjunctive therapies may be used in pulmonary embolism patient. Supportive care like pain management. For pain management, we give acetaminophen, non-steroidal anti-inflammatory drugs for pleuritic pain, narcotics if needed, fluid and oxygen given based on clinical need. If there is failure to improve, we should consider the complication like pneumonia or recurrent pulmonary embolism. Early ambulation is preferred. We should encourage ambulation as soon as possible if the patient is stable. Bed rest 12 to 24 hours may be needed for patient with large clot or severe symptom. Compression stockings not routinely recommended to prevent post-thrombotic syndrome. Used only in selected patient with DVT who develop post-thrombotic syndrome. Inferior vena cava filters, they are used if the anticoagulation is contraindicated, for example, high bleeding risk, if pulmonary embolism recurs despite proper anticoagulation. In selected high risk cases, for example, poor cardiopulmonary reserve, not really recommended for pulmonary embolism patients. Some experts use temporary IVC filters in high risk patients. The prognosis of pulmonary embolism, morbidity, and mortality. If pulmonary embolism is untreated, 30% mortality is seen. If treated with pulmonary embolism with anticoagulation, the mortality rate is 2 to 11%. Mortality decreases due to better diagnosis and treatment. Early prognosis in first 3 months depend. The highest risk is first 7 days. Patient with shock presents in 8% of the patients. Mortality risk is 30 to 50% highest in first 2 hours. The management is always considered thrombolysis or embolectomy instead of anticoagulation. Patient with recurrence risk is highest in first 2 weeks, in it then declines. Recurrence rate on anticoagulation, it is 2% at 2 weeks and 6% at 3 months. Late prognosis, that is beyond 3 months, mortality risk 5 years mortality is 32%, mostly due to comorbidity like cancer, MI, and sepsis. 30 years mortality 3 times higher in pulmonary embolism patient versus matched control. Recurrence risk is 8% at 6 months, 13% at 1 year, 23% at 5 years, 30% at 10 years. It is risk is high with unprovoked pulmonary embolism or malignancy, and it is reduced with indefinite anticoagulation in high risk patient. Chronic thromboembolic disease and chronic thromboembolic pulmonary hypertension occurs in small subset of the patients, and it manifests as a progressive dyspnea within 2 years. Reduced exercise tolerance improves over 1 year. Risk factor for poor recovery are female sex, obesity, lung disease, high pulmonary artery pressure. The poor prognostic factors are shock and right ventricular dysfunction. Shock, it is the strongest predictor of the death. RV dysfunction or echo or CTPA increases twice the mortality. Laboratory markers like high BNP, anti-proBNP indicates the right ventricular strain. Elevated troponin, they are associated with high risk of death, high mortality if these markers are elevated. high right heart thrombus seen in 4% of the pulmonary embolism patient, 80% in critically ill, and it is associated with the right ventricle dysfunction, early mortality. The take home points are early mortality is highest in first 7 days due to shock and recurrent pulmonary embolism. Mortality decreases with anticoagulation from 30% to 2 to 11% if treated early. Recurrence risk highest in first 3 months, then stabilizes. Long-term mortality mostly due to comorbidities. Poor prognosis is with shock, RV dysfunction, high BNP, and troponin, high right heart thrombus. So, monitoring and follow up of the pulmonary embolism patient, monitoring the anticoagulation therapy. If we are giving heparin or unfractionated heparin, we should monitor APTT. Target is 1.5 to 2.5 times the upper limit of the normal. For warfarin, we should monitor INR. The goal is 2 to 3, target is 2.5. For LMWH, this direct oral anticoagulant like apixaban, rivaroxaban, dabigatran, no routine lab monitoring is required. Adjust anticoagulation in kidney failure, pregnancy, weight changes, or drug interaction. The early complications are seen in first 1 to 2 weeks. We should watch for worsening symptoms or recurrences. We should consider echocardiography or MRI if symptoms suggest PFO or stroke. Late complications up to 2 years are we have to monitor for recurrent pulmonary embolism, chronic thromboembolic disease, or chronic thromboembolic pulmonary hypertension. If persistent breathlessness develops, evaluate chronic thromboembolism, embolic pulmonary hypertension. We should consider repeat imaging like CTPA, VQ scan, echocardiography if recurrence or CTEPH is suspected. The complication of therapy or bleeding risk, we should monitor for major or minor bleeding, heparin-induced complication, watch for thrombocytopenia, osteoporosis, warfarin-specific or monitor for skin necrosis, cable filters, we should monitor for migration or thrombosis, risk of recurrence bleeding, we should reassess anticoagulation need periodically. We stop if major bleeding occurs, continue if minor bleeding or recurrence happen. Inferior vena cava filter management, if placed due to anticoagulation contraindication, retrieve once anticoagulation can be started. Identifying underlying risk factor, we should look for malignancy, inherited thrombophilias, recent surgery, conduct risk factor evaluation as needed, and follow-up clinics. Some institutions have specialized pulmonary embolism clinics for better long-term monitoring. Management of recurrence on therapy, we should check for inadequate anticoagulation. It is the most common cause. Common reason for subtherapeutic anticoagulation, malabsorption, for example, GI disorder, improper intake of rivaroxaban, missed doses or discontinuation of procedure, poor compliance, drug interaction like warfarin, DOAC, weight changes affecting low molecular weight, heparin dosing, heparin resistance, for example, increased heparin binding proteins. So, we should increase the heparin dose in such cases. If using unfractionated heparin, we should switch to IV unfractionated heparin for monitoring. If oral drugs are suspected to be ineffective, we should consult a coagulation specialist if unusual drug metabolism is suspected. We should assess for suboptimal therapy. Patient at risk are those treated with IVC filter without anticoagulation, embolectomy or thrombolysis alone. Action is we should restart optimize anticoagulation when possible. We should look for ongoing prothrombotic condition. The possible causes are cancer, May-Turner syndrome like iliac vein compression, inherited clotting disorder like protein C, protein S, antithrombin deficiency, antiphospholipid syndrome. Here, if patient is on warfarin, we should switch to low molecular weight heparin. If patient is on low molecular weight heparin, we should increase the dose. We should consider IVC filter if recurrence develops despite adequate anticoagulation. We should consider the other causes of recurrences are mechanical obstruction, for example, pelvic mass, IVC filter, thrombus. Action is to treat the underlying cause and remove mobile thrombus. If there is misdiagnosis, PE likely symptoms occurs in pulmonary tumor embolism, fat embolism. We should consider alternate diagnosis if atypical presentation is there. Just to summarize, whenever patient comes to us with sudden dyspnea and tachycardia with normal X-ray, we should always suspect pulmonary embolism. We should categorize such patient or we should do the risk stratification by using well score. And if the well score is supportive, we should do d-dimer for low risk patient, ctpa for high risk patient. If the patient has a massive pulmonary embolism, we should thrombolize him. If the stable pulmonary embolism is there, we should start anticoagulation. And we should always monitor INR for warfarin and APTT for heparin. And we should do the follow-up for recurrences and uh, pulmonary hypertension. Maya Angelou has said, they may forget your name, but they will never forget how much you made them feel. With this, I conclude my today's topic. Thank you. Keep learning.